we are going to look at is the apical four-chamber view of the heart. For this, we would like the patient again in the left lateral position with the left arm under the head, if possible, whenever feasible. And it would be ideal to have the patient at the edge of the bed for this position, for this window, because we are going to have the probe right underneath the patient, right here. And it will be easier if the patient is at the edge so that we have room to go and look for the image. We are going to start scanning just below the left nipple. It's usually just inferior and lateral to the left nipple in men, and under the left breast and lateral to the left breast in females. So we are going to start scanning, and again we are going to start looking for a good window to see where we get a better window. The ideal position of the probe is going to be with the probe indicator towards like 5 o'clock position right here. It's not very down, not down to the ground, not like the 6 o'clock or 7 o'clock position, but rather slightly towards rotated anti-clockwise so that it's towards the 5 o'clock position. And we are going to try to get image where we see the left ventricle LR apex right below the probe. So I'm now window shopping and see right here we have the good image coming up. Alright, just go to full screen and adjust the gain a bit and go back to full screen. And here for this view, getting the patient to take a deep breath and exhale, you might feel it moving as the apex shifts. It might shift down one space below, or it can go up one space up. So we don't have an ideal breathing cycle for the apical view, but you will have to find as the patient breathes which gives a better view, and you can ask them to hold at that point. So what we are seeing in an apical four-chamber view is we are going to see all four chambers of the heart. Here we have the left atrium, the right atrium, the left ventricle, and the right ventricle. We have the mitral valve and the tricuspid valve. The apex of the heart is formed by the left ventricle, and that needs to be right under the probe. If it is towards the left like this, then the right ventricle is under the probe. Then you move the probe towards the left side laterally to get the apex of the heart right under the probe, as we see here. And as you can see, we are looking at the left ventricular thickening, and the base of the mitral annulus moving up and down, indicating good LV function right here, and it is thickening well. And you see the mitral valve opening and closing. You want to make sure that the left atrium is smaller than the left ventricle, and the right atrium is smaller than the right ventricle. The right ventricle size should be smaller than the left ventricular size, and the right ventricle does not go all the way till the apex, rather it stays before the apex. When there is right ventricular hypertrophy, you're going to see this change. And you're seeing that the tricuspid annulus here is moving well up and down, and that indicates good right ventricular function. We will see that in tricuspid annular plane, systolic excursion is a measure of a right ventricular function by measuring how much the tricuspid annulus goes up or down, right? And you can put color to evaluate the mitral valve and the tricuspid valves. You see that there is good flow. There is no flow acceleration indicating any stenosis across the mitral valve, and there is not much of regurgitation that we see, which indicates normal function. And we are going to evaluate the tricuspid valve with color. As you can see, the tricuspid valve is not well visualized now, so it can be better visualized by just moving the probe towards the right side of the heart a bit when you want to evaluate the tricuspid specifically. And still moving the probe to get a better view. As you can see, the right side, the tricuspid valve better, and we see there is not much of a regurgitation or stenosis. The next is to see, right now I am making motions of the probe can distort the image, and what kind of motion can cause what kind of image distortions, or what are you seeing on the screen right now. That will be depending upon how your probe is moving. So here again we have the 4-chamber view, and when I move the probe left or right, basically tilting the probe left or right is again going to cause rocking motion of the heart left or right on the screen, which we saw in the parasternal views. And now tilting the probe to point more anteriorly by pushing the tail of the probe towards the patient's abdomen is going to cause a change of a cross section through the anterior part of the heart, and that brings us the aortic valve into the view right there. So we were at the 4-chamber right there, and tilting it anterior is going to cause the aortic valve to come into the picture. The ideal cross section would be to have this view directly perpendicular, vertical under the probe. And when we do the opposite by tilting the probe head towards to look straight down into the chest, or the tail towards the left shoulder, what we are coming to see is the coronary sinus here posterior to the left atrium. From the 4-chamber, coronary sinus, and from the 4-chamber to the aorta. On the 4-chamber view of the heart again, here we have the vertical axis of the ventricle, straight vertical 90 degrees to the probe, and this is again tilting of the probe will gonna bring other structures into the view. Right now the aorta is coming into the view, which can be used for measuring the velocity time integral and calculating cardiac output through the LVOT outflow right here. And tilting the probe in the opposite direction with the tail pointing towards the patient's left shoulder is going to bring the coronary sinus, which is the black structure right here that you're seeing. The aorta and the coronary. The 4-chamber view can also be used to measure the left ventricular function by using the Simpson's biplane method. The other things to look for are the evaluation of the valves. You will see that the valves should remain below the level of the annulus That if it comes below, the mitral valve comes towards the atrium, beyond the annulus, then it's going to show prolapse, mitral valve prolapse there.